My name's Courtney Bunner. Oh, started a little bit too early. My name's Courtney Bunner. I'm one of the ID pharmacists here at Ruby. Today, the topic is endocarditis, and I'm going to be focusing on talking about some old dogma, but with some new evidence sprinkled in, specifically about adjunctive therapy and staph PVE. So I'll review the role of adjunctive rifampin and GINT in staphylococcal prosthetic valve endocarditis, or PVE, which I'll refer to it as throughout the presentation because it's a lot easier. So to start, just a review of staph prosthetic valve endocarditis. As we know, it does have a high mortality rate, and it's one of the most severe forms of endocarditis, ranging from around 25 to 74%, depending on the species and patient-specific factors and how it's managed. So, part of what makes staph PVE or staph infections in particular difficult to treat is the presence of several virulence factors. So, these organisms are able to promote biofilm formation on prosthetic material. They facilitate bacterial cell aggregation and stabilize the extracellular matrix. And all of these things contribute to persistent infection and antimicrobial tolerance, making it a little bit more difficult to treat. So, because of these challenges, treatment strategies for staph PVE have historically relied on combo antimicrobial therapy, which I'll discuss next. Looking at the 2015 IDSA endocarditis guidelines, so around almost 11 years ago, which is crazy, the recommended treatment for staph PVE includes combo therapy, like I said. So the backbone of therapy is an anti-staph beta-lactam like nafcillin or oxacillin, or vanc if it's an oxacillin-resistant staph strain. Um, and in addition to that primary or backbone agent, the guidelines recommend using adjunctive rifampin for at least 6 weeks. And then they also recommend using gentamicin for at least the first 2 weeks of therapy with the goal of providing gram-positive synergistic activity. So overall, this regimen carries a class 1 recommendation with level B evidence, meaning it's strongly recommended, but it's only supported primarily by moderate quality or limited clinical data. So part of the rationale behind adding GINT in certain endocarditis regimens is for gram-positive synergy, like I said. Historically, combining a beta-lactam or vanc with GINT was thought to provide that synergistic bactericidal activity, allowing for more rapid bactericidal or bacterial killing. However, as we all know, there are some concerns with using aminoglycosides. We have to use therapeutic drug monitoring while the patient is on an aminoglycoside to ensure we have appropriate drug levels, but also while minimizing toxicity. We're also probably very well aware of the toxicities that can occur with aminoglycosides, most notably nephrotoxicity, sometimes ototoxicity, and less commonly CNS toxicity. I stole this image from Drew, so I'm not going to go through the football analogies because I'm not a football person, but I'll explain the mechanism just in general. So this illustrates the concept of gram-positive synergy. So on the left, when gentamicin is used alone in gram-positive infections, it doesn't really have the ability to reach its target inside the cell because of the thick peptidoglycan wall acting as a barrier. So the drug has reduced intracellular activity, which allows the bacterial cell to survive in the presence of GINT alone. And then on the right, we see when there's the addition of a cell wall synthesis inhibitor like a beta-lactam or vanc, it allows for disruption in the cell wall, creating gaps, and then it allows gentamicin to be introduced into the cellular wall, acting on the 30S ribosomal subunit, inhibiting protein synthesis and creating bacterial death. Um, So this all supports the use of using a beta-lactam or VANC, or just a cell wall synthesis inhibitor in general in serious gram-positive infections like endocarditis. Next slide. So while aminoglycosides were historically added for synergy, another adjunctive agent that's commonly recommended is rifampin, largely because of its activity against staphylococcal biofilms on prosthetic material. With rifampin, it has inherent activity against Staphylococcus species in general, and it's theoretically could be useful in prosthetic infections because it can penetrate gram-positive biofilms so well. And these are thought to play an important role in infections involving prosthetic valves and other implanted material. However, rifampin does come with significant concerns like drug-drug interactions due to the strong enzyme induction, which can affect medications like DOACs or warfarin, making it a little bit more difficult to anticoagulate these patients, as well as hepatotoxicity. And rifampin has a low barrier to resistance when it's used alone, so it should never be used as monotherapy. And it's typically only recommended after blood cultures have cleared when the bacterial burden is lower. So, although both of these are still recommended in the guidelines as adjunctive therapy, it's important to look at what evidence those recommendations were originally based on. So, this slide kind of summarizes the evidence based behind those recommendations. For rifampin, a lot of the rationale comes from the in vitro biofilm activity and animal foreign body infection models with very limited clinical evidence. Primarily, they do reference an early case report involving only 2 patients. And you can see these studies are from a while ago, from 1978 and in the early 90s. Um, with Gent, it was supported mainly by similarly in vitro synergy with other agents, and then animal infective endocarditis models with rabbit studies from 1984, which suggested that combining VANC plus rifampin plus Gent could be effective in endocarditis. But looking at all of this data together, one thing that does become more apparent is that most of the support for adjunctive rifampin and gentamicin comes from in vitro studies and animal models with very limited clinical data. So, because of that limited clinical evidence base, there's been some more recent studies that have begun to reevaluate whether these adjunctive agents actually improve outcomes in staph PVE. So, one of the more comprehensive evaluations came from this study by Ryder and colleagues published in 2022. They performed a meta-analysis of 4 studies evaluating adjunctive rifampin and gentamicin in staph PVE. And overall, the analysis found that adding either Gent or rifampin did not reduce rates of clinical failure or infection relapse compared with regimens that did not include these agents. In addition, toxicity was a significant concern. So about 31% of patients receiving rifampin had to discontinue therapy due to severe adverse events like hepatotoxicity, nephrotoxicity, cytopenias, and significant drug-drug interactions. Based on all of these findings, the authors did suggest that current guideline recommendations for adjunctive rifampin and gentamicin and staph PVE may warrant downgrading. And looking beyond meta-analyses, this is one of the larger individual studies that also evaluated the role of adjunctive rifampin in staph PVE. It was a multi-center retrospective study including 180 patients with staph PVE. And of these patients, about 56% were treated with rifampin as part of their regimen. Of note, about 28% of these patients underwent valve surgery, although the outcomes in the study were not stratified based on surgical versus medical management. Just something to think about. Overall, the investigators didn't find any significant difference in 1 year mortality or relapse rates between patients who received rifampin and those who didn't. And rifampin use was also associated with longer hospitalizations, which could have reflected complications like adverse events or management of drug-drug interactions. So, if these traditional adjunctive agents might not provide the benefit that we once thought, a question to consider is, are there better combo strategies out there? And when do we use combinations in staph PVE specifically? Next slide. Looking at this slide, it does highlight several recent studies that have evaluated combination therapy in MRSA bacteremia specifically. This figure comes from a systematic review, and it summarizes the available literature examining different combo regimens in MRSA bacteremia. One important point illustrated here, and I think there's an animation if you just click next, Chantry. It just shows that many of these MRSA bacteremia studies include a pretty significant portion of patients that have endocarditis or other endovascular sources, which are shown in those blackish, grayish bars. However, it is important to recognize that most of these studies were designed to only evaluate combo therapy for MRSA bacteremia in general, rather than specifically studying treatment strategies for staph PVE or for the full duration of endocarditis therapy. For the sake of time for this session, I'm not going to go into the individual studies evaluating each of these regimens, but there are a few combination strategies that have gained attention in the literature, and some of us are very well versed in, especially now. One commonly studied approach is daptomycin combined with the beta-lactam, which commonly is ceftazidime, which we use a lot here at Ruby, which might provide some synergistic activity through the seesaw effect, which potentially enhances daptomycin activity against MRSA. Another regimen that's been explored is dual beta-lactam therapy, probably the most common being cefazolin plus ertapenem. That's been used in cases of persistent MSSA bacteremia to help achieve more rapid clearance of the bacteria. In clinical practice, these combos are often more reserved for cases of persistent bacteremia with the goal of achieving faster clearance and then stepping down to monotherapy once blood cultures become negative after around 72 hours. However, this kind of raises an important question for us of should these regimens remain salvage strategies for persistent bacteremia, or is there a role for earlier combo therapy in Staph aureus bacteremia infections with a higher inoculum, like Staph PVE, which we all know should be potentially addressed in our Sabedia trial going on right now? So, to wrap things up, I just wanted to highlight a few considerations that might help guide decision making in patients with staph PVE. So, when thinking about adjunctive therapy and staph PVE, source control, I think, is a big factor for the management of specific patients. So, if infected hardware or the prosthetic valve is surgically removed, it's important to question whether rifampin still has benefit, given that the main rationale in using rifampin is relating to biofilm activity on that prosthetic material. So if we remove it, do we need it? And in that Laybot study that I discussed a little earlier, it didn't demonstrate clear benefit with rifampin, even when only about 28% of patients underwent valve surgery, meaning that most patients were medically managed without definitive source control. But again, they didn't stratify outcomes based on or comparing medically managed versus surgical patients, which would be interesting to look at in the future. It's also important to think of patient-specific factors, including the potential for drug toxicities and then drug-drug interactions, mainly with rifampin. And because of those concerns, we might also consider alternative combo therapies up front in our higher inoculum infections. So finally, this obviously remains an evolving area, and we should continue to monitor new literature that comes about. One important ongoing study is the Staph aureus Network Adaptive Platform, or the SNAP trial. It's currently evaluating adjunctive rifampin versus no rifampin in Staph PVE. And hopefully studies like the SNAP trial will help provide that higher quality clinical evidence that historically has overall been lacking in this area. And that is all I have. I'll take any questions or comments.